We shall start the class now. So today topic is clinical pharmacology, toxicologies and poisoning. And the speaker we have here is Dr. Asif Iqbal, who is a HOD Respiratory Critical Care and ECMO Services at Apollo Multi-Speciality Hospital, Kolkata. Thank you, sir, for being with us. You may start.
Good evening, students. Today I will take classes on the clinical pharmacology, toxicology, and the poisoning. It's a huge chapter. This is not a one day next to impossible possible to finish. So I will take this subject in 3 class because it is a very important subject for the MRCP part 1 and the part 2, and also you will get lot of question in MRCP part 1. You will get 20 mark question from the clinical pharmacology, 10 marks question from the toxicology and the poisoning. So you are understanding that the total 30 marks question will come in particular this segment. And this segment is basically very if you know the answer, you will get the correct mark, or if you don't know, then and it easy to get scored in this particular area because the pattern of question is very similar. So if you know the pattern, you will be able to give the answer. So now coming to our first question. And before starting this, regarding the clinical pharmacology, you should remember the area where from the question come. The first area, that is your basic pharmacology, like drug metabolism. There are a lot of questions will come from the drug metabolism, and you have to read thoroughly about the cytochrome P450, because there are a lot of question coming from the different type of question will come from the cytochrome P450. And also you have to have knowledge about the phase 2 and phase 3 reaction, and also you have to have the knowledge on the drug excretion and the drug interaction. The most of the question on the pharmacology, that is depend on the drug interaction and the side effect, adverse effect of the drugs. So though it is called clinical pharmacology, but the question will come from the respiratory drugs, from the cardiology drugs, from the antipsychotic drugs, from your chemotherapeutic drugs. So, though it is a clinical pharmacology, but you are getting the drug interaction of the adverse reaction of different system wise. So let's come to our next first question. That is 19-year-old woman presented in the emergency department. She had row with her boyfriend and took a handful of her mother tablet, which she found in the bottle. And her mother has multiple health problems, including hypertension, reflux esophagitis, dyslipidemia, night cramp. The patient complained of involuntary spasm affecting the left side of her neck, particularly sternocleidomastoid, and feel very upset. On examination, her blood pressure is high, 155 by 90 mm. Which one of the following the drug which most likely have taken? So this question particularly asks about your this question particularly asks about the side effect of one of the drugs. So your key point in this question, one is the involuntary spasm and other is the sternocleidomastoid, particularly sternocleidomastoid. So any one of our aspirant can tell me what problem she is suffering.
Yes, the answer is metoclopramide, and
Why?
most likely due to EPS, extrapyramidal syndrome. Most likely.
Very good. So this is the involuntary spasm and the sternocleidomastoid is the features of extrapyramidal syndrome, and particularly the sternocleidomastoid is the very specific for your sternocleidomastoid spasm is very specific for the first sign of the extrapyramidal syndrome. So she is suffering from the extrapyramidal syndrome, and metoclopramide is the causative agent. So what other drugs which cause extrapyramidal syndrome? So you are right. So what other causes of extrapyramidal syndrome? So extrapyramidal syndrome is a symptom that are typically associated with extrapyramidal system of brain cerebral cortex. This include movement dysfunction such as dystonia, continuous spasm of muscle contraction, akathisia, maybe manifestation and motor restlessness, Parkinsonism, characteristic symptom. This sometimes is mimic like a Parkinsonism, rigid bradykinesia, tremor, and tardive dyskinesia, that is irregular jerky movement. So causative agent, the most common typical antipsychotic associated with this extrapyramidal syndrome is haloperidol or fluphenazine. Other anti-dopaminergic drug like metoclopramide, and short and long-acting use of antidepressants such as selective serotonin reuptake inhibitors, serotonin norepinephrine reuptake inhibitors, norepinephrine dopamine reuptake inhibitors. So most of the antipsychotic drugs, they do cause the extrapyramidal syndrome, and non-medication related extrapyramidal syndrome, like if the patient suffering from meningitis. Now, what is the treatment of extrapyramidal syndrome? The treatment varies with the type of symptoms. Like if there is a severe spasm, then anticholinergic has a good choice of drug. If there is a dystonia, anticholinergic. If there is a akathisia, then beta blocker like propranolol are frequently used to treat akathisia, and other medications sometimes used include clonidine, benzodiazepine, and pseudo Parkinsonism, because it's a symptom mimic like a Parkinsonism. So pseudo Parkinsonism is a then the drug of choice is anticholinergic and amantadine. So the patient who are getting long-term antipsychotic drug, they might mimic like a Parkinsonism symptom. So you have to think about your think about the extrapyramidal syndrome. Now coming to our next question, that is 43-year-old woman with a long-term history of manic depression psychosis come to emergency department, and she has nausea, diarrhea, lightheadedness, feel weak and lethargic. Her lithium level
Excuse
is
me, sir.
excuse me, yeah, is measured 2.5 millimole, and recent history noted that she has begun course of metronidazole for dental abscess. Which of the following most likely cause of her lithium toxicity? So this patient, psychotic patient on lithium, and now he developed lithium toxicity because you are now anyone can tell me the what is the normal level of lithium in the body?
1.5.
1.5, 1.5 to 2. Okay.
Right.
So it is also called narrow spectrum, narrow therapeutic window index of this drug. So the patient develop lithium toxicity. Now, what is the exact cause of lithium toxicity in this particular patient?
Most likely reduced renal clearance.
Yeah. So metronidazole cause metronidazole cause reduce excretion of the lithium through kidney. So what other drug causes the decrease excretion? One is non-steroidal anti-inflammatory drug, include cyclooxygenase COX-2, AC inhibitor, angiotensin 2 receptor antagonist, thiazide diuretics, corticosteroid, tetracycline like antibiotic. They also decrease your reduce renal clearance. Now, lithium toxicity, one of the important area of your MRCP part 1 question. So you have to know about the lithium toxicity. So lithium toxicity means lithium overdose. Symptoms include tremor, increased reflex, trouble walking, kidney problem, and altered level of consciousness. Some symptoms may last for year after level return normal, like serotonin syndrome. Lithium toxicity can also occur due to excessive intake or decreased excretion. Excessive intake by either by suicidal in nature or accidental, and decreased excretion may occur result of either dehydration, such as vomiting, diarrhea, and low sodium diet and kidney problem. And the diagnosis is generally based on symptoms supported by lithium level. Usually, 1 to 1.5 is the normal range. If it is more than 1.2, you might have the develop sign symptom. The treatment, acute treatment is gastric lavage. Whole bowel irrigation may be useful in done in early. Active charcoal has not effective. So if the question have active charcoal, then it is not, you have to give the not effective treatment. And for severe toxicity, the treatment is hemodialysis, and risk of generally low in the lithium toxicity, and acute toxicity generally has better outcome than the chronic toxicity. So chronic toxicity happen when it is contaminated with water or in a long-term use of lithium for bipolar disorder. Now, coming to our next question, that is 45-year-old.
Sir, excuse
Yeah,
me, sir. Can you? Your slides are not visible fully.
not visible fully. Just a minute. What happened? Why not visible fully? Now see. Now it is visible.
Yes, sir. Yes.
Okay. So 45-year-old man who has hypercholesterolemia has recently been started on cyclosporin for the treatment of moderate psoriasis, come to the emergency department complaining of extreme lethargy and multiple muscle ache. Other medication note include rosuvastatin. The examination revealed tenderness over his claves, thigh, shoulder, generally muscle weakness. And the investigation report, hemoglobin is 10.9, white cell count 13,000, platelet 1,87,000, sodium 143 millimole, potassium is 5.7 millimole. So potassium is little higher side, creatinine is little higher side, creatinine kinase is high, alanine aminotransferase is 721. So the question is, here is, which of the following is the most likely cause of his man presentation? So what do you think? What is the problem here? Yeah.
This is
The following is most likely cause of this man presentation. Yes.
most likely due to rhabdomyolysis,
Okay. The
statin.
diagnosis is suffering from the rhabdomyolysis because creatinine
Yes,
kinase is high, potassium is little
very high.
higher side and complaining the body ache. Okay.
Yes,
It is the side effect of the statin, rosuvastatin
statin.
side effect. Now, why it is
Right.
happening?
Due to some interaction with the statin, maybe the rosuvastatin interaction. the cytochrome P450/3,4A inhibition.
Cytochrome P450 inhibition in statin.
Uh,
So that is the important area, cytochrome P450. You have to know that in and out about the cytochrome P450. It has a 60 isotope, and this isotope has different type of action. Some are inhibitor, some are inducer. So you have to know the cytochrome related drug interaction. But surprisingly, in statin with your this drugs has no cytochrome related drug interaction. So here rosuvastatin is substrate of hepatic uptake transporter OAMP1B1 and efflux transporter for breast cancer resistant protein BCRP. Agent which interfere with the function either these two transporter can therefore lead to significantly elevated level of rosuvastatin and presenting with myopathy seen by cyclosporin inhibitor of. Basically here the cytochrome P450 is not causes the drug interaction, though the causative agent here, causative agent is your cyclosporin. Cyclosporin have good the cytochrome 3A4 inhibitor, and which causes the increased level of the lot of drug, but in particularly in statin, the drug interaction not due to the cytochrome P450 pathway. It is the pathway it inhibit this protein B1 transporter block, act as a transporter blocker, and therefore rosuvastatin not able to enter the hepatic cell, therefore their metabolism is inhibit and it causes the accumulation of statin, and therefore there is a it has an adverse reaction, overdose adverse reaction. So rosuvastatin use prevent cardiovascular disease in those at high risk state of abnormal lipid. Common side effect: abdominal pain, nausea, headache, and the muscle pain. Serious side effect include the rhabdomyolysis, liver problem, and diabetes. Like all statin, rosuvastatin work inhibiting by HMG-CoA reductase enzyme found in the liver that play the role of producing cholesterol. Rosuvastatin has multiple contraindications, include hypersensitivity and any component with formulation active liver disease, elevated serum transaminase, pregnancy, breastfeeding. These are the contraindication. Drug interaction. The commutin anticoagulant warfarin can affect the removal of rosuvastatin, cyclosporin, colchicine. The drug may decrease the level or activity of the endogenous steroid hormone like cytidine, ketoconazole, spironolactone. Additional medication. So additional medication for high cholesterol such as clofebrate, fenofibrate, and these all cause your high cholesterol level. And specific protease inhibitor including atazanavir when taken with ritonavir, this also cause the increased level of rosuvastatin. Alcohol intake should be reduced while rosuvastatin to decrease the risk of developing liver damage. Aluminium magnesium hydroxide antacid should not be taken within 2 hours of taking rosuvastatin because it decreases the absorption. Co-administration rosuvastatin with eluxetolin may increase the risk of rhabdomyolysis and the myopathy. And grapefruit juice negatively interact with several specific drug of statin class, but it have little or no effect on the rosuvastatin. Now coming to the next question, 25-year-old woman admitted in admitted to the hospital with severe diarrhea following treatment with coamoxiclav for bad throat infection. Stool culture yield Clostridium difficile. She become dehydrated, requiring IV fluid, and is unable to tolerate oral medication, owing to her sore throat. Okay. So,
The answer is
what is the best
vancomycin.
IV treatment? Yes.
Vancomycin, the drug of choice in Clostridium difficile.
Okay. So, drug of choice, vancomycin, yes, good. But the key factor, the keyword of here, she become dehydrated, requiring IV fluid and unable to tolerate oral medication, being her sore throat. So the patient not taking the not able to taking the oral medication. So the drug of choice is vancomycin, yes, and the second drug of choice is your
Erythromycin.
no metronidazole.
Oh, metronidazole. Okay.
Metronidazole.
Right.
What happened? Yeah. So metronidazole is the drug of choice in particularly that case, because the metronidazole, which can be effective in the C. diff, it can enter the colon by oral route, and also it can penetrate the colon through IV. So parenteral treatment, because the patient not able to take orally, so your vancomycin will not go to the gut, because IV vancomycin not penetrate the colon, therefore it will not work on the colon. But metronidazole has both oral and IV, both route. There is a good penetration in the colon. That's why
Oh,
the answer in this particular case is metronidazole. So your key point of this question is that she become dehydrated, requiring IV fluid, and is unable to tolerate oral medication, owing to her sore throat. Understand? So that is the key point. So in MRCP examination, most of the question have some twitching sentence. So you have to be very careful when you will think that the question is looking very easy. So first thing, you have to check twice, because they try to make you fool. So next question, 56-year-old woman presented in the emergency department with subacute history of progressive breathlessness. She also complained of dry cough, although she denied fever and chest pain. On examination, her respiratory rate 22 beats per minute with oxygen saturation 94 on air. That dropped 91% on exertion. Auscultation revealed fine respiratory cackle at the base. History revealed that she is taking number of different medication. It is suspected that one or more of these may have caused her lung disorder. So the keyword is the auscultation revealed fine inspiratory cackle on the base, and breathlessness, dry cough, and she has a fever and chest pain. Okay, so which of the following most likely cause patient presentation? Atenolol,
is it
captop,
nitrofurantoin? Nitrofurantoin causing lung
Captopril, sir.
fibrosis.
yeah.
Nitrofurantoin causing lung fibrosis.
Yes. So here the keyword of this question is auscultation reveal fine inspiratory crackle at the base. So fine crackle always it is due to your ILD. In MRCP, if there is a given fine crackle,
Yes,
so
sir.
think about the ILD, and if there is a coarse crepitation, then you think about the heart failure. Okay. So the drugs which cause the lung fibrosis is nitrofurantoin here. Okay. The patient has pulmonary fibrosis, given history, progressive shortness of breath, dry cough, and fine inspiratory cackle on auscultation. Pulmonary fibrosis recognize adverse effect treatment with variety of drug, including busulfan, methotrexate, amiodarone, bleomycin, and nitrofurantoin. Captopril causes cough. Okay. Angiotensin converting enzyme inhibitor may cause reversible dry cough 10 to 20% of the patient, but they do not do the pulmonary fibrosis. Similarly, diltiazem also not causes pulmonary fibrosis. Just a minute, हाँ मैं कॉल कर लेता हूँ.
So unmute yourself, please.
Okay. So ibuprofen can exacerbate bronchoconstriction, particularly patient with hypersensitive airway like asthma, but do not cause the lung fibrosis. Next question. Yeah. Next question. 62-year-old man is admitted with acute medical take with symptom of lethargy and the heart failure. You understand he had a dental extraction few weeks earlier and has been feeling progressively worse since then. On examination, he looked unwell, is pyrexia. His blood pressure is 125 by 77 mmHg. His pulse is 95 breath per minute and regular. He has a systolic murmur. Additionally, you notice splinter hemorrhage and a vasculitis rash. So the investigation report, hemoglobin is 10.2, white cell count 11,000, platelet is 2 lakh, nearly 2 lakh, and ESR is very high, 82, sodium and potassium more or less normal, creatinine is little higher side, and blood culture group A hemolytic streptococcus. Which one of the following is the most appropriate antibiotic regimen? So what is happening here? Anyone can tell me?
Most likely infective endocarditis, splinter hemorrhage is a classical sign.
Okay, systolic murmur is there also.
Yes, so let's see what are the choices.
So what antibiotic you will give?
B.
Benzoyl penicillin and gentamicin. And any other choice? Anyone?
Benzyl penicillin and rifampicin.
Benzoyl penicillin, rifampicin. Okay, let's see. Actually, benzoyl penicillin and gentamicin. So antibiotic in endocarditis, the scenario suggested
Right.
diagnosis of bacterial endocarditis. Combination with benzoyl penicillin and gentamicin may be appropriate. Benzoyl penicillin given the one thing is that in the MRCP, all choices will be very close. Okay. So why benzoyl penicillin and the rifampicin is not? Because very narrow antimicrobial coverage. Flucloxacillin also, the spectrum is narrow. So gentamicin is your aminoglycoside group, and benzoyl penicillin is your BLBLI. So it has a wide range of coverage. And why not for vancomycin? Also, it is narrow spectrum of activities. And now coming to the penicillin is normally continue for 4 to 6 weeks, whereas gentamicin administered for short period of time, typically 2 weeks. The success rate for antibiotic therapy is around 95% for native valve Streptococcus endocarditis. Now coming to your next question, you are reviewing 46-year-old patient with renal transplant clinic, and he has been receiving cyclosporin for past 18 months. Which of the following most likely to represent adverse effect of cyclosporin treatment? So alopecia, chronic intestinal nephritis, myelosuppression, stomatitis, and urolithiasis. So I would
Myelosuppression.
say the most of the question coming from adverse effect or drug-drug interaction. So chronic interstitial nephritis is the answer. The
Right.
main use of cyclosporin to reduce T-cell immunofunction for transplant patients, so reduce chances of rejection, to reduce chances of rejection like your solid organ transplant, and cyclosporin has narrow therapeutic index requiring therapeutic drug monitoring. Renal toxicity is more common with high drug concentration more than 200 nanogram per ml, whereas rejection is common with low serum level. Adverse effects include chronic interstitial nephritis, hyperkalemia, hypertrichosis if it is nephrotoxic but virtually non-myelotoxic. So alopecia, why it is incorrect? Hypertrichosis is a common side effect of cyclosporin rather than the alopecia. Myelosuppression, incorrect, because it is a immunosuppressive agent, non-myelotoxic. Stomatitis is not recognized adverse effect of cyclosporin, and urolithiasis is not recognized adverse effect of cyclosporin. So my request, when you will read this pharmacology, just when you will get the question, you go to the KD Tripathi and you at least you read 2 or 3 areas of particular drug. One is the drug-drug interaction. Second is the adverse effect, mechanism of action. This 3 area is very important for particularly the drugs, and most of the question you will get on in this area only. Now coming to the another question, that 64-year-old man presented with severe several months of weight loss, anorexia, palpitation, and his wife mentioned that he keeps the house temperature cool as he's generally feeling too hot. He has a background of ventricular tachycardia for which he has taken amiodarone for some years. On examination, he has a slight tremor, appear thin. His heart rate is 105 per minute. There is no goiter present. Blood tests are taken. Thyroid TSH is very less and free T4 is little higher side. He is subsequently referred for ultrasound scan of the neck, shows absent vascularity and probable gland destruction. So what will be your appropriate treatment here? So what problem is suffering?
Patient is
I
having
AI
hyperthyroidism.
type 2 AI,
Hyperthyroidism.
Hyperthyroidism.
type 2
Hyperthyroidism.
Type 1 or type
And
2?
type 2.
type 2.
Okay. And
And
what drug you will give?
Prednisolone.
propylthyroid.
Prednisolone.
Yes. Let's see. You guys are prepared for part 1. Well, good. Coming to the answer. So what is the effect of amiodarone in thyroid gland? Amiodarone induce hypothyroidism, and also amiodarone induce thyrotoxicosis also. Okay. So in this particular case, amiodarone causing the thyrotoxicosis, and there are 2 types of thyrotoxicosis, type 1 and type 2. Type 1 is due to excess iodine induced thyroid hormone synthesis, and here you will get the goiter, and the management of the drug is carbimazole or potassium perchlorate. But in the amiodarone induced destruction thyroiditis is goiter is absent, so it is basically is a type 4 hypersensitivity reaction. So you need to prevent this. So corticosteroid is the drug of choice. Okay. So amiodarone should be stopped if possible. Patient who develop thyrotoxicosis and autoregulatory phenomenon where thyroxine formation is inhibited due to high level of circulating iodine. Now coming to next question. 32-year-old lady is admitted to hospital with 3-day history of throbbing headache bilaterally associated with photophobia and phonophobia and photophobia. On admission, there is no neck stiffness, no focal neurology deficit, or no rash. Her background history is that she is patient of depression, and for which she on citalopram 20 milligram OD. She admitted for observation, but throughout the night she complained worsening pain. As such, she is prescribed number of analgesic medication. These include paracetamol, ibuprofen, codeine, tramadol. The next day, she developed pyrexia, stiffness, and the rigor, which are short-lived and settle with paracetamol and cooling technique. One of the nurse has noted that during this event, her pupil appeared dilated. When you examine her, she appeared comfortable with mildly increased tone. Blood culture were taken, blood tests are repeated. So hemoglobin is 12, platelet is normal, WBC is slightly raised, neutrophil is 74%, lymphocyte 35%, eosinophil 3%. Sodium, potassium is more or less normal. Urea and creatinine also normal, and CRP is little higher side. She still require analgesia and 6 to 8 hours later develop the same symptom. Which would you do the next while is waiting for repeated blood test? So repeat blood culture, arrange urgent MRI, arrange urgent LP, withhold citalopram and withhold tramadol.
This whole
So what
tramadol.
exactly problem is?
Without
Serotonin.
citalopram. Without citalopram.
So what exactly problems he has?
Serotonin syndrome.
So
Basically, there is serotonin syndrome.
serotonin syndrome. She is suffering from the serotonin syndrome. That's why when the citalopram concentration increase, he has developed the symptom. So what do you know about this serotonin syndrome? You have to know what is serotonin syndrome and what is the causative cause of the serotonin syndrome, and monoamine oxidase inhibitor and serotonin reuptake inhibitors and amphetamine. These are the drugs which cause the serotonin syndrome. Features: neuromuscular excitation, hyperreflexia, myoclonus rigidity, autonomic nervous system excitation, hyperthermia, sweating, and altered mental state, confusion. Management: supportive care including IV fluid, benzodiazepine. More severe cases managed using serotonin antagonists such as cyproheptadine and chlorpromazine. So you have to know about the serotonin syndrome and also neuroleptic malignant syndrome. This both have a similar kind of sign and symptom. Okay. So give me example of one drug which cause neuroleptic malignant syndrome.
Haloperidol.
Yes, very good.
Haloperidol.
So thank you guys. Today I covered a bit of pharmacology part and I will request the coordinator give me a 3 class on particular this topic, because it is a very vital and important topic. Next day I will I will take some classes on the poisoning part, and third day I will take some classes on toxicology part for the MRCP examination. So I will recommend all of you for particularly this. There is no specific question for this this area, but you will get all type of question. All systemic drugs have their own side effect and drug-drug interaction, and uh, try to figure out this area. Like in a cardiovascular system, you have to know the antiarrhythmic drug and their drug-drug interaction, and particularly digoxin is a very good choice for MRCP examination. In your respiratory system, theophylline, doxophylline is the area, and also beta adrenergic drugs, and all chemotherapeutic drug, and particularly newer biological and newer chemotherapeutic drug, their side effect and their drug-drug interaction. And for basic pharmacology, you have to know about the drug metabolism, cytochrome P450, and also you have to know the bit about your therapeutic index and all. Though there is you will not get the basic question from the basic pharmacology, it will be a related question. So best of luck, guy, and thank you.
Thank you, sir. We shall do the next class soon. Thank you.